Okay, hello. It's Professor Mike and his trusty teaching assistant here to learn about eating disorders. Let me give him some coffee. Hold on, 'cause I need coffee. It's very early in the morning right now. Some coffee for him, some coffee for me, and we're ready to go. Okay, I got everything positioned differently, so let's do our best here. So, the epidemiology of eating disorders have been around for centuries. There's a possible relation to fasting. We know that some religions fast. Saint Catherine of Siena, no, not the hospital, was known to purge. She was a saint, obviously. It appears to be increasing, especially in modern countries. 8% of adolescents, mostly women, although increasing in men also. It tends to begin in adolescence, these disorders, as most mental health disorders do. We know that most mental health disorders begin in late adolescence, early adulthood, and usually they've manifested by the age of 28, 29, or 30. It has the highest mortality rate of any other mental disorder, between 5 and 20%. So eating disorders are very, very serious. It is classified as Axis 1. I realize we have not gotten to the axi of mental disorders. We'll talk about them when we get to assessment. So hang in there. Etiology, meaning causation. Biologic, it tends to run in families, as does most other mental illnesses and physical illnesses. So there is a genetic component here. It may be related to a defect in chromosome number 1. And it seems to be related to a serotonin deficiency, which by now you should be able to associate with depression and anxiety. So those disorders, depression and anxiety, are going to run comorbid many times with an eating disorder. Psychologic, low self-esteem, again, low serotonin level. Early severe childhood trauma can cause this also. Here we have the depression. Also witnessing sustained and severe marital discord. So once again, an unstable childhood. People and children can endure intermittent stressful events. It's when they're non-remitting, chronic, and never going away, such as in disasters and war, things like that. Also here we see affective instability. Again, affect means mood, so an unstable mood. Socioculturally, society here, we know the fashion industry values very thin women. Diet industry, once again, very thin. Mass media, portrayal of thin women on TV. A drive to succeed like men. Men tend to be thinner. So a woman younger subconsciously may see it, if I'm thin, I'll be more successful. Also, with more women getting involved in sports, there's a trend to want to be thin with less body fat. And a woman is gonna possess more body fat than a man because that allows them, in yesteryear when there wasn't enough food to survive, that she had reserves so she could take care of her children. Family issues, overly controlling parents, enmeshed, overprotective families. Enmeshed means the boundaries between the individuals in the family are not clear. A family should be a group of individuals that gets together, maybe used to be 3 times a day on the farm, but maybe twice a day now, or even once a day. Breakfast and dinner, or just dinner. A group of individuals that gets together. How are you doing? Discussing things, but they are separate individuals. Enmeshment means that the boundaries between the individuals is now distorted. For example, if a parent is an addict or an alcoholic, and the oldest sibling possibly has to rise up and become the parent in the family. In other words, the boundaries of who does what job is not clearly defined, enmeshed. Also here, food is used as a source of control, so it's now being weaponized. What happens now, as the child is shunned from expressing emotions and has no control, possibly from very dominating parents, the child learns to use food as a weapon of control. Again, here children are discouraged from expressing themselves, stuffing family conflicts. A healthy family can talk things out. In fact, some of you who have been to the rehabilitation unit at the hospital, there's a community meeting every morning where all the patients get together with the staff and discuss issues of what's going on with the unit. And common issues might be stop drinking all the coffee, men lift the toilet seat up when you use the toilet, things like that. So it's very important that a healthy family can discuss things without getting excessively emotional, because yelling and screaming does not foster communication. Okay? So the patient resorts to eating disorder as a way to gain control over conflicts. Comorbidity, like I said, depression, generalized anxiety disorder, body dysmorphic component here. Again, we spoke about body dysmorphic disorder in the anxiety lecture. This is in the person's mind's eye, in their view of themselves in their mind. They have some dysmorphic shape or something is not right. But to the other people around them, they see nothing wrong. So in terms of an eating disorder, the person who has this, in their mind's eye, they see themselves as overweight, when in reality, they may very well be very underweight. Okay? Dissociative disorder, substance abuse, and borderline personality disorder, which we'll get to in a day or two. Again, I say, can you think of a neurotransmitter that is deficient in most of these illnesses? And the answer here is serotonin. So let's look at types of eating disorders as per the DSM-4. We are now at the DSM-5, as you know, so there's been some changes, but not a lot. I'll talk about the change in just a minute. Anorexia nervosa literally means nervous weight loss. It involves self-starvation, possibly combined with a distorted body image. Once again, in the patient's mind's eye, their view of their body is not accurate. It's not to the level of psychosis. We could almost think of it as a cognitive distortion. There are two subtypes, and I will not test you on the subtypes, but you should have an idea. Restrictive type, meaning you're not eating a lot of calories, and the binge and purging type. So your binging means you're eating a lot of calories at one time, and then you're purging possibly with laxative or vomiting, things like that. Criteria for diagnosis: refusal to maintain body weight less than 85%. That has been the change in the DSM-5. You don't need to be at 85%. That would be 15% less than your ideal BMI, body mass index. Okay, it's no longer criteria, but you are less than your ideal BMI. Distorted body image: see self as very heavy in mind's eye, like I've said. Intense fear of gaining weight. And your self-worth is determined by weight. And what do I mean by that? When you lose a pound or two, you feel very good about yourself. If you gain a pound or two, you feel terrible about yourself. So your self-worth is being determined not internally, but by weight gain or loss. So let's talk at some signs and symptoms of anorexia nervosa. Obsessed and compulsive with food or weight loss. Sensitivity to cold, that would make sense. If you're not taking in calories, you can have you're going to feel cold. A decreased pulse rate, sunken eyes, protruding cheekbones. We see this was very common in victims of concentration camps during World War II. They were basically just skeletons. Very, very sad. Possible facial hair growth, particularly in women. When they're not eating enough, their body is going to shut down and not really function ideally, so they may have some facial growth, hair growth. Constipation, possible decreased interest in sex, and the hallmark here is denial of low weight problem even though they're very thin. So they deny that they have a weight problem even though we see them as very thin. So let's talk about bulimia nervosa. These patients tend to be of normal weight. Again, two subtypes, purging and non-purging. There are criteria for diagnosis here. Recurrent episodes of binge eating followed by extreme weight loss measures such as laxatives, enema, excessive exercise, etc. And these patients can become addicted to laxatives, actually. We have to be careful with that when they get admitted to the unit to search their stuff. As we know, all psychiatric patients have their possessions searched for things that could be used to hurt them. In this case, in addition to things that can be used to hurt them, we're going to be looking for laxatives. There's a feeling of a loss of control over food intake, and that may very well be true. They just binge on food and then have to purge to get rid of those calories using laxatives or vomiting, things like that. And again, a feeling of self-worth determined by body shape and weight. Let's look at some signs and symptoms here. Yellow, stained, and eroded teeth. And what's happening here as this person purges and vomits, the stomach acids actually erode the teeth, because we know in our stomach we have hydrochloric acid, and there's a yellowing and staining of the teeth. We can look at their fingers of their dominant hand, usually the right hand. Most people are right-handed, and you can actually see a callus on the knuckle from them putting their finger down their throat to make themselves vomit. Well, this chronic vomiting can cause what's called esophagitis, inflammation of the esophagus, and possible tearing of the esophagus. Very, very serious here. Again, the esophagus is not made to have hydrochloric acid in it. Hydrochloric acid is made to be in the stomach and probably parts of the small intestine. Dehydration and electrolyte imbalances. If you're not eating properly, you're not taking in enough salts. Just so you know, when we speak about electrolytes, we're talking about salts in the body, sodium chloride, things like that, which are all involved with the nervous system, the sodium-potassium pump, and many other functions. Low blood pressure, hypotension, cardiac arrhythmias due to these electrolyte imbalances, hypoglycemia, low blood sugar, swollen parotid glands on the side of the cheeks get swollen, and menstrual dysfunction. Again, if you're very, very thin, your body is going into survival mode and you might not menstruate in a normal fashion. Okay, so the nursing process here. Well, we're going to look for low weight. That's a definitive. A less lower BMI than should be. Stained or eroded teeth, an obsession with food. So if people are, as we know, on the psychiatric units, people tend to eat together because we want to encourage socialization. As opposed to in a med-surg floor, we're more worried about infection control. On a psych unit, we're not worried about infection control. We want to foster socialization because, as I've said, human beings are the most social animals on the face of the earth. Okay. So we want to see if this person is obsessed with their food, fiddling with their food, cutting up their food in ways, separating their food on the plate. We have to observe for that. We want to observe for calluses on the fingers. Again, I've spoken about that. We can look at lab values, or the doctor will order the lab values. We should be familiar with them. Usually what will happen is the printer will churn out some lab values and you can look at them. Fortunately, most lab value documents have the normals right on there. We can look for EKG changes and other signs and symptoms of eating disorders. Well, what can we do? Questions we can ask during the assessment process. Is the person satisfied with their weight and body shape? Current weight and past history of weight. Do they go up and down? Do they diet a lot? Are they obsessed with weight to the point of affecting concentration? Again, this is the OCD component here, that they're so obsessed with their weight that it distracts them from other thoughts in life. A history of laxative use or abuse, a history of vomiting after a large meal. Again, somebody may deny this, but we can look at their fingers on their dominant hand to see if there's a callus. Some nursing diagnoses here. Let me see if I can get this on the screen a little bit. There it is. Certainly ineffective coping. Okay. I tend to think of ineffective coping as drug use, but certainly purging and binging with food is ineffective coping for emotional problems. Electrolyte imbalance, certainly risk for self-harm, certainly a disturbed body image, chronic low self-esteem. Again, we can add here things like depression and things like that. So what do we want to achieve? Again, if we do a care plan, What do you want to achieve? Well, I always say that you want to get rid of the data that got you to the diagnosis. Okay, so let's take a look here. I also want to add one more thing. When you do a care plan, you need to have an achievement date. At what date do we expect to meet this goal? Without a date, when the students give me care plans, without a date on their outcome column, I write the patient will never get discharged from the hospital because they need to achieve this goal before they're going to get discharged. So, reduction of presenting signs and symptoms, that they're starting to gain weight. Their lab values are getting back to normal. Maybe the patient can gain some insight into emotions and their behaviors. For example, every time they speak to one of their parents who they have a conflict with, they want to purge or not eat, something like that. Patient becomes aware of family enmeshment problems, that they realize that the family's enmeshed, that there aren't clear boundaries between family members. I remember when I was working in a hospital, we had a woman, 24 years old, very, very thin, diagnosed with anorexia nervosa. Tried to get her well, and her mother came in to visit, and the mother started to rearrange this patient's room, talking to the daughter, saying, honey, you didn't make your bed, please make it better, fold your clothes, this is so messy here. And I'm saying to myself, ma'am, back off on your daughter. Back off on your daughter. Well, let's think about that. What disorder might this parent have? And it could be the mother or the father. Probably an OCD here. Again, you have an anxiety disorder in the parent that is being put on the child, and the child learns the only thing I can control, that mommy can't control or daddy can't control, is the food I eat and if I purge or vomit. Okay, so now again, food is being weaponized here. Okay, maybe again the patient here can learn about these enmeshment issues. Long-term goals. The patient must commit to therapy. Okay? And I want to make it clear that most mental, if not all mental disorders, work best if they're at a very high level with medication and some kind of talking therapy, whether it's Freudian, cognitive, behavioral, something like that. To just give somebody medication does not resolve the underlying conflicts. Okay. Now, some people might not need medication, that they can resolve them on their own. But if they're unable to talk about these problems and issues, a medication can calm them down so they can address their psychological issues. Although we know that most psychiatric disorders have a biologic genetic basis, there is an environmental trigger. And as I've said in lecture, for lack of a better analogy, genetics loads the gun and environment pulls the trigger. And that would apply to cancer also, okay? Because most physical disorders have an underlying genetic component to it also. Okay, so long-term goals. Going to see a therapist, a psychiatrist. There's a group called 12-Step Anorexic Anonymous that they can go to also. What do we want to do? Well, once again, we have to establish a therapeutic alliance. And as we know, this is the cornerstone of all mental health care. That the patient has to realize we are on their side. We are not against them. And as you know, many patients that get admitted to a psych ward against their will are very angry. They don't belong there. They don't want to be there. Our job as nurses is to, one, orient them to the unit, and while orienting them, letting them know we are on their side. We're not against them. Our whole goal in mental health care is to have the patient become who they want to be in a mentally healthy way. Okay, we have no agenda except to get people healthy. As I used to tell veterans at the VA when I worked there, I want to see you on the golf course having a great life. That's the whole purpose of this. Okay, let me just lower my heat because it might be making some noise in the microphone. Okay, I am back. We want to monitor eating patterns. How much are they eating? They play with their food, observing them. We want to observe for purging after food, after meals. So it might not be that uncommon to have someone with an eating disorder eat their meal and then get up while everybody else is sitting and go to the bathroom. What would we do in that case? We would follow this person to the bathroom and have them leave their door open a little bit so we can make sure they're not purging. Okay, again, we're not against the patient. We're here to help them get healthy. And I want to say something else. We have to always remember that mental health disorders are not logical. If we expect logic, we're not going to get that. These are illogical, and this is why they're disorders, okay? It's emotional. Make sure the person does not have laxative. We're going to make sure when they get admitted by searching their stuff. We want to put in a dietary consult, have the dietitian should look at the lab values, see if the person needs more protein, more salts, things like that. We want to keep a lab values, like I said. Make meal times a positive experience. So meal time should be low stress, should have some joy, there should be some conversation, things like that. We want to avoid power struggles over food. We don't want to, in other words, they're using food as a weapon. So we want to de-weaponize the food, the eating experience. So we don't want to get in power struggles over food. We want to weigh them twice per week. Again, working with this woman who had anorexia nervosa. The doctor wrote an order, we have to weigh this person twice a week, and this is my first time working with someone with an eating disorder. I got the scale out of the room, and she stood on the scale backwards. I said, wow, this is interesting. So when we were done, I obviously recorded her weight, and I went to the charge nurse and said, I'm a little bit confused. Why is this person standing on the scale backwards? And the head nurse, who had treated other patients with anorexia, said, we don't want the person to know their weight because their self-esteem is based on whether they've gained weight or lost weight. We want to take that out of the equation, okay? So they don't need to know their weight. We want to de-weaponize that. We want to encourage verbalizations of thoughts and feelings, very, very important. Again, the only way we know what's going on in someone's head is by the words that come out of their mouth. We also can get an idea of that by observing their behavior, but we want them to talk about what they're feeling, their emotions, their thoughts. That gives us data. We want to assist a patient in gaining insight into how food is used as a source of control, usually regarding the loved ones. I spoke about that earlier. Educate patient and family about enmeshment issues. So really, ideally, we can get the patient well, maybe get the patient to gain weight, but we need to address the family and how the family deals with issues. If I could have spoken to the mother of this patient I spoke about a few minutes ago, I would have sat down with the mother and said, your daughter's 24, she's an adult. If she doesn't want to make her bed a certain way or doesn't want to fold her clothes, that's okay. She's an adult now. We can have a behavioral contract with rewards for weight gain, that if a person maybe gains 2 pounds per week, and that's really the goal here, that they might get more privileges such as going off the unit, things like that. We do want to avoid being overly sympathetic. Again, sympathy denotes pity. Empathy is, I can't feel your pain directly. I'm going to try to help you. But sympathy is, oh. So we want to avoid that. And what can happen if we give them sympathy, we want to avoid secondary gains. Secondary gains means they have an agenda now, possibly as attention-seeking, to gain attention with this eating disorder. Remember, a healthy adult can self-soothe and self-support. A mentally healthy adult learns how to calm themselves. Yes, it's nice to have friends to help you, but ultimately the adult can handle it themselves. On the other hand, a child needs a parent to soothe them. That's okay. But as an adult, above the age of maybe 19, 20, 21, we should be getting to the point that we can soothe ourselves from anxiety. We want to refer to a therapist, cognitive therapy. Again, Beck, Burns, Ellis, the book Feeling Good I spoke about at the beginning of the lecture. They address cognitive distortions. Psychodynamic, psychoanalytic, this is Freudian. They deal with feelings. The therapist can address family enmeshment issues. And there are many therapists that are eclectic, meaning they have experience with cognitive behavioral therapy and psychodynamic therapy, so they can combine them both. Again, Anorexic Anonymous, behavioral therapy, 12-step meetings, other types of group therapy. If you have people with an eating disorder in the group, or it's actually best to have a mixed group with mixed diagnoses, but people begin to realize that other people have problems, that they're not alone in their problems, and that's called universality. Okay, a group should be a safe place to disclose and talk about feelings and emotions. Let's talk about medicinal treatments here. The drugs of choice are antidepressants. Once again, this is connected to a serotonin deficiency, so we want to use an SSRI. The drug of choice tends to be Prozac. Okay? Although Zoloft would work, Prozac has a longer half-life, which in this case can be advantageous, meaning if the patient misses a dose, they're not going to have their mood dip very quickly, because Prozac has one of the longest half-lives of all the SSRIs. In fact, it has an active metabolite. When it goes through the liver, the metabolite that's produced, norfluoxetine, also has antidepressant properties, which gives Prozac a half-life, an effective half-life of about 2 weeks. So you could miss a day or two and really feel no change in your mood. On the other hand, Zoloft or Lexapro with a shorter half-life, if you missed a day or two of dosing, you would probably feel a dip in your mood. Well, by increasing serotonin, we can decrease depression, decrease anxiety, decrease body dysmorphic symptoms, and obsessions and compulsions with food. But there are some early symptoms of Prozac that we should be concerned about. Well, since I'm not in front of lecture, Prozac can cause weight loss in early treatment. In fact, Prozac started out being studied as a weight loss drug. But the people studying it, Eli Lilly, who was a drug manufacturer who developed Prozac, noticed after about 3 weeks or a month, the anorectic effect, the weight loss effect, went away. But what they did notice was people's moods were elevated. And they said, holy mackerel, we have just stumbled upon a possible new novel antidepressant. They did studies on it, and they submitted to the FDA, and the FDA approved Prozac, the first SSRI for the treatment of depression. And we also realize it helps treat anxiety also. There's another antidepressant which should never be used here called bupropion, a brand name Wellbutrin or Zyban, should never be used. And I asked the question why, and the answer is because people that are prone to seizures, it can induce them in higher doses, but people with electrolyte imbalances, people with eating disorders, are more prone to seizures. So Wellbutrin would never be used here. Okay. Let's look at biological treatment for severe cases. So this is someone who comes in totally emaciated, quite sick, and they need medical care. Well, we want to give IV hydration with electrolytes. Okay. TPN, meaning total parenteral nutrition. And what that means is basically you're getting everything you need to survive through an IV. This solution looks like a milky liquid that goes directly into your vein, bypassing your digestive system. It's basically pre-digested food that goes directly into your vasculature. Or we can use NG tube feedings, nasogastric tube through the nose to put food into the stomach. Caloric intake should begin at about 1,000 to 600 calories a day. Remember, these people might be eating 2, 3, or 4, or 500 calories a day. The normal caloric intake for an average adult is about 2,000. For a young person, it might be 2,500 to 3,000. So we start out at about 600 calories a day. We increase to about 2,000 to 4,000 a day. The goal here is to gain about 2 or 3 pounds per week. In fact, if anybody's gone on a diet, the goal is generally to lose 2 pounds per week. If you're losing more than 2 pounds per week, it's probably liquid water, And that's what these fad diets do. They say you could lose 7 pounds in 1 week. You'd have to physically starve yourself. More than likely, you're not drinking a lot of water, and water's quite heavy. It's 8 pounds per gallon. So every quart that you drink, you lose 2 pounds. But gaining back here, the goal here is to gain about 2 or 3 pounds a week. If the patient is severely emaciated, overfeeding can lead to death. And this actually happened during World War II in concentration camps. My uncle was involved, two of my uncles, actually all of my uncles were there, but two of my uncles saw combat, and one of them was liberating concentration camps, and the GIs were giving the victims in the concentration camp their chocolate bars, because GI soldiers had chocolate bars, and they would give them the chocolate bars, and the person would pass away because their body was so starved of nutrition. The energy it took to metabolize that chocolate bar was too much for the body to handle. If patient is dependent upon laxative, a stool softener or high fiber diet can be added as laxatives are reduced. So these patients can come and literally addicted to laxatives. Well, if we take away the laxative, they might get constipated. So what we can do is we can add a stool softener, Colace, Pericolace, sodium ducosate is the generic here, okay, or a high fiber diet. Conclusion. These are chronic illnesses, as most mental disorders are. They get worse in times of stress, as most mental disorders do. So most mental disorders get worse in times of stress. In times of stress, we release adrenaline and dopamine. Think about that. They are excitatory. Dopamine can lead to psychosis in high doses. So really, anxiety is what can trigger these. Again, the best results here are obtained with medication and some form of psychotherapy. Again, if you have any questions, you can feel free to email me. I believe you all have my email address, and I will answer questions. Okay? Let's see if I can get this to turn off. Or better yet, maybe I can just go to a different lecture here. Let's see. End slideshow. Click on notes. This is not cooperating. What do we have here? Doesn't look like it's going to work. How do I end show? Let me try this. Let's go here. Well, I think that's all I'm going to be able to do here. Okay, so I'll get another one posted in a day or two. Keep studying, everybody. Don't let this get ahead of you.